Chapter 14, Bleeding, Shock, and Soft Tissue Injuries. Damage occurs during trauma, and when that happens, we have the need to take care of bleeding and shock and all this other issues, right? We could have internal bleeding, which results in shock. Shock is a state of collapse of the cardiovascular system that doesn't deliver adequate blood and nutrients to the body and the organs, and then people begin to die from shock than any other condition. So trauma is nothing to be thinking that is easy or something to be taken flippantly. So how are we going to start? What will we do to start treating a patient with injuries? Size up. We start like we always start. We do it like we always do. We will look these patients over, starting with the scene size them. What's the mechanism of injury? What's the number of patients? Additional resources. Consider C-spine. General impression of the patient. AO4, chief complaint. The whole thing. We're going to go through there to figure out what's going on. Size up the scene. Then go after that primary assessment. What's going on with the patient? Then start taking a history if they're conscious to do so. And then find out anything that's wrong and fix it. We have to be methodical in our patient assessments if we're going to find the issues that are wrong with the patients and keep them from dying. Now, with trauma, we have basically a golden hour that we've got to get them from the point that they're injured to the point that they're having definitive care at the hospital. So our time is best spent in stopping the major things and then getting them transported out of there. We need to make sure we're safe, right? And we need to stop doing other things if the patient's losing blood. We have to stop the bleeding. And then we have to treat for the ongoing signs of blood loss, which is shock. Pale skin is going to be another sign symptom that we're going to see, with an increased blood pulse rate and a decreased blood pressure. These three things together, it's just screaming at you, shock. I'm in shock, I'm in shock, I'm in shock, I'm in shock. Now, obviously, when there's bleeding and there's disruption to blood tissues and there's wet, sticky, and not mine, I want to make sure that all of my body is taking and prevented from mixing with all of their body, because they could have potentially infectious diseases or this is or that. We don't want any of their methyl bad stuff on us. Always wear gloves. If it's spurting blood, if there's a lot of juices going everywhere, maybe you want eye protection and surgical masks as well. In the context of a pandemic like we just went through, maybe you need to think about protecting yourself a little bit deeper, like if I want an N95 on rather than a surgical mask. Now, this is a review. This is from our chapter on anatomy physiology way back in the beginning of the book. It's showing you the circulation through the system, right? We saw it earlier as a connection to more of the lungs, the pulmonary functions. But this is the circulation of a drop of blood through the system and how it tracks, right? And it gets to these places by the pump. So we have the pump, the pipe, and the fluid, the heart, the vessel, and the blood, which are consistently the needs of a good cardiovascular system. If one of those is damaged, like in the instance of being, like a deep laceration or internal bleeding, I'm losing that one leg to stand on, if you will. Now, we know from this picture here that there are many different places to go. Left atrium goes to the left ventricle goes out into the arteries and veins of the body, starting with the aorta, which is the largest artery, then the arteries, then the arterioles, and then we do a double diffusion at the capillary bed. We get into the venules, and as we start coming back up into the veins, now we're into the vena cava, the largest of the veins, as it dumps back into the right atrium, right ventricle, right? And then we're out through the pulmonary vein into the lungs to do a double diffusion, and then we're back by the goes out by pulmonary artery comes back through pulmonary vein. Now note that the veins and the arteries in the pulmonary system are reversed. Okay, so that takes us to the pump of the heart. A close-up version of this looks very specifically at those uh, pieces, right? We have two atria and we have two ventricles. And the right and the left atria never mix blood, and the right and the left ventricle never mix blood. It's right to right and left to left. Atria are the upper, ventricle are the lower. So some of the pipes, obviously we talked about in that bigger expanded version, was the blood vessels, the arteries, the veins, the capillaries. And these are the things that are going to take your blood where they need to go. So we have to know what's normal first before we start talking about what is abnormal. Here is a imaging from, I think it's like an electron imager. It's pretty cool. You got white blood cells and red blood cells and plasma, which is the fluid part, and platelets, which is your clotting cells. And you can see each has a different function. The red blood cells carry the oxygen and to the cells and carry carbon dioxide away from the cells. The white blood cells are your defenders. They fight against bacteria and viruses that are invading the body. Your platelets stop things from bleeding, right? It clogs things up. And of course, the fluid part, the plasma, is the medium in which it all floats. Now, as the heart beats, it creates a pulse wave. And any time that an artery comes across a bone, we'll be able to feel that pulse wave. Right? In a conscious patient, we feel that it's a pulse at the wrist, which is the radial, which is at the base of the thumb. And then in an unconscious person, we do the carotid first. Okay, so that's our normal stuff. Now let's talk about the abnormal. So when we're talking about bleeding and shock is defined as failure of the circulatory system. I have a failure of either the pump, the pipe, or the fluid. I've got pump failure, I've got pipe failure, I've got fluid loss. Right? Those are going to be the main reasons why. Now, there's other reasons that cause shock, but it's going to be creating a problem in one of these three areas. They give you a couple in the book, and you can look up, there's so many more. But cardiogenic shock is when the heart cannot pump enough to meet the supply of the body, right? Such as in, I'm having a heart attack, right? And you also see blood backing up in vessels in the lungs, resulting in congestive heart failure. Again, a problem with the pump. So if I see CHF, I maybe have cardiogenic shock beginning. Now, pump failure is caused by expansion of the capillaries so big that it doesn't matter how fast that pump works, it's just not gonna fill those pipes up. And because of that, it's like losing prime on an engine, right? There's just not enough fluid there to create a pulse wave that causes that osmosis going on there. It could be that the capillaries and the vessels are too big. It could be that there is a rupture of them. In any case, there's not enough fluid in the pipes to do what's needed because the pipes have dilated to the point where they're useless. It'd be like all of a sudden going from a half-inch water supply line to a 3-inch water supply line with no increase in volume. It wouldn't work. Shock induced by fainting, which is psychogenic. I scare the crap out of somebody, or they come up against something that really bothers them. Everything kind of just relaxes to the point where it just bottoms out. Those vessels dilate, the pipes dilate, and you pass out just because you're scared, right? The nervous system dilates everything up, and it's too much for the body to compensate for, and the patient passes out. So if you lay them down, cover them up and give them some oxygen, they'll probably pop right back in short order. Another type of pipe failure is anaphylactic shock. This is due to an extreme, life-threatening allergic reaction. and the blood pressure is dropping because we're got too much pressure in the chest area, okay? Because they can't breathe. Coupled with the fact that we're having some vessel expansion and not enough pump pushing out, we result in that shock atmosphere, and death will result quickly if we don't take action against anaphylaxis. Of course, the action here is epinephrine, right? Septic shock is because of being sick, and the pipes are all kind of, think of them like they've been corroded from the inside, and there's little holes in them now. They're leaking throughout the body with all this icky stuff that is the infections. Um, Typically, we see this in the older adults, especially those that have a weakened immune system. Spinal shock is also known as neurogenic shock, and this is after somebody has been had a hit to their spine. There's been some sort of an injury to the spinal cord. Now, the injury allows the capillaries to expand and blood pools below where we need to go. And so we're going to see signs and symptoms of shock above the injury because the brain knows that there's a problem. And yet below the injury, the brain doesn't know what's going on. So we might have pooling of the blood in the lower extremities or lower areas simply because the rest of the body doesn't know there's a problem in the upper body. Okay? And so that spinal shock, that neurogenic shock, you're going to have a slow pulse and a low blood pressure. And everything's going to look normal below the injury point, but above the injury point, they're going to show signs and symptoms of shock. So you may or may not have a blood pressure that's going with you on that. So we talked about the pump, we talked about the pipes, let's talk about fluid loss. This is hemorrhagic shock. This is where I bleed out too much. Now this is straight up, I've got a cut, I've got a broken bone, and my heart is attempting to maintain pressure in the pipes by pumping faster. Well, if I'm bleeding out, now I'm bleeding out faster, right? We're bleeding out worse. And then eventually, because there's no blood there, we move into the state of cardiac arrest because there's nothing to pump. So the heart just says, okay, well, I give up then. External bleeding, pretty easy to find. Internal bleeding, maybe not. Some signs we may see with internal bleeding: bruising, swelling. I'm not real concerned if it's in an arm or a leg, yes. Okay, but abdominal area, going to be very hard because there's a lot of space there you can bleed into. And severe pain in the immediate area, especially if it's like the chest area, we could really be dealing with a lot of blood and not a lot of visual references that they are in fact bleeding. And so we're going to have to know what mechanism caused this injury so that we can stay on top of potential treatment plans that will need to be initiated to keep people from dying. Now, in a normal human creature, there is about 12 pints, 6 liters of blood circulating around. So if you think about it like this, 3 2 liters. What's your favorite drink? Soda. 3 of those is basically what an adult creature has circulating through their system. But 2 or more pints, 1 liter, so half of one, you'll start seeing signs and symptoms of shock. You get more than that, now you're going to get altered out in some severe signs and symptoms of shock. Okay? As shock deprives the body of sufficient blood flow, right, it progresses and causes other areas to fall, to fail. The first of which is going to be your mental status. I'm going to be confused and agitated. I'm not going to understand what's going on as my cold, clammy skin, my diaphoresis sets in. So these are the first things that kind of go kittywampus, and you might see them even passing out from like a psychogenic / hemorrhagic shock. The breathing is going to be altered as it attempts to correct the need by breathing faster, the need for the body to have oxygen and get rid of carbon dioxide. It's going to breathe faster to try to counterbalance that. The pulse is going to be rapid and weak because there's a problem with one of the three things: pump, pipe, or fluids. Um, and if I check a cap refill, it's going to take a minute. It's going to not a minute. It's going to take longer than normal to refill. Normal cap refill is you press it, press the finger or whatever, and it blanches. You let it go, and you say capillary refill. It should be refilled. So within 2 seconds. So a refill time of greater than 2 seconds, we're starting to see signs and symptoms of shock. That's most special for the pediatric patients. Okay, they begin to get nauseous. They begin to feel like they want to vomit. Then maybe they're weak or fainting, and they're very thirsty. These are all signs and symptoms of shock. So what do we do? Well, let's start into the general treatment plan for shock. This goes across the board here. We're going to place the patient, especially if they don't have a head injury, laying on their back. Right? You want to lay them on their back. Now, some of the old way of treating shock was to elevate the legs. If it's in the protocol, do it. If it's neither for or against it, your choice, dealer's choice. But we're going to start by, laying them at least flat, so that the heart, if that's the problem with it, that's causing the problem with shock, at least it doesn't have to work so hard to, defy gravity. It just has to pump horizontally. Obviously, we're going to treat ABCs. Any problems with the ABCs, we're going to find them, we're going to fix them. That should go without saying, but we're going to list it here because that's what we always say, that's what we always do. We go through their ABCs, 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 ABCs. And we're going to treat the root cause of the shock if we possibly can. If they're bleeding, we're going to stop it, right? If they're having an anxiety attack, we're to slow them down. To maintain body temperature, we're to cover them with a blanket, right? And just let them relax. Try to calm down. Now, what I'm not going to do for somebody in shock is I'm not going to let them eat or drink anything. Because the last thing I need them to do is to choke on something or to vomit or whatever else. And we don't know what's going on the inside. Maybe we have a ruptured spleen. Maybe we have a ruptured stomach, a ruptured or blocked large intestine. We got to make sure that nothing's flipped around in there that's going to cause additional damage just because we want to have, they want to eat something. Plus, if they need to go into surgery, they really shouldn't have eaten anything for the last 8 hours. Now, with these traumas, obviously they need to be transported. We're not always going to be there by ourselves. EMTs will show up to transport, paramedics will be there to transport. You are trained to give oxygen, so do that. The advanced EMTs or paramedics, they're going to start giving the fluid replacement to kind of replace some of that lost blood. But if we don't stop the bleeding, then they're just going to be bleeding out the fluid and not the blood. So we've got to make sure that they're getting those people buttoned up best as we can and transported out of there. We can't help them in the field. We have to treat them and get them to a definitive care facility, appropriate definitive care facility. So we're not burning time in the field trying to make everything look pretty. We're trying to do our absolute best for them. Prompt transport by an ambulance to an appropriate medical facility gives the patient the best chance of survival. Failure because of the septic shock, now we'll be a little bit more specific. Transport as soon as possible, epi-auto injector, right? We already know that. Neurogenic shock, backboard, C-collar, treat for shock, get them transported. Septic shock, ABCs, treat for shock, get them transported. Pretty much the same thing all the way around. Now, internal blood loss, we're gonna treat for shock. That's absolutely a true statement. But how do we know they have internal blood loss? Well, they might actually show some external signs in different places. They might start coughing or vomiting up blood. That could be a sign of internal bleeding. Their belly, their abdomen is tender. You maybe see some bruising across the abdomen. I'll tell you right now, if you see bruising across the abdomen, that's a significant injury because it takes a lot of force to bruise an abdomen. It's distended, that's another thing. If I have bleeding out of the rectum dang near killed them. Um, but if it's coming out of the rectum, that's a sign that there's an internal issue. Now, they listed here vaginal bleeding in women. Uh, we got to be careful that we don't assume that, oh, they're just on their period or whatever else. Uh, so if they're bleeding out the vagina and it's not their time, that is a bad sign. They've done a lot of damage to their girl parts on the inside when things are leaking out. And quite frankly, if the men are bleeding through their penis, we've got some severe internal injuries as well. And you can see the regular signs and symptoms for shock. We'll have to treat that as well. Okay. Now, when we talk about external bleeding, we're talking about something we can see and take care of. Three different pictures here. You have the capillary bleeds there, the owie boo boos, the paper cuts. But then you've got the venous bleeds, which is a free flowing bleeding that you see there on the leg there in letter B. But if you have spurts going on, it's spurting in time with the heartbeat. Now that's arterial, and we're going to have to get some work done here. Direct pressure to the site for capillary bleeds, we're pretty much good to go. That's the road rash. That's the light skins. That's the pinpricks and things like this. Now, venous bleeding is a steady flow. Typically, a little bit. It's more common than arterial bleeds, but less common than capillaries. Uh, Veins are the return system. They're a low pressure system. Uh, Fairly easy to damage. The bleeding is a steady flow. If we apply direct pressure and really do our job, we should be able to control that. The problem comes with the arterial bleeding. So it's the spurts. Each time the heart beats, there's a spurt of blood. If I don't get a handle on this fairly quickly, they're going to bleed out, go into hemorrhagic shock, maybe even into irreversible shock, and we've lost them just because I didn't want to get bloody. So we need to make sure that we are using our direct pressure, or make sure that we are, if we can't control it with direct pressure, we're throwing that tourniquet on there and stopping the blood flow like right now. So direct pressure, and then a pressure bandage would be a good thing to do over that, right? We want to make sure that they're not going to continue to bleed. Now, if for whatever reason direct pressure doesn't stop it, we need to go right to the tourniquet. Lay that tourniquet on them and make sure that you shut off the blood supply. Then you can go back and finish with your bandaging and your dressings, okay? Now, sometimes there's hemostatic agents. They've been developed by the military for traumas that rapidly clot off the bleeding if used properly. Most of the times for us, we'll see these hemostatic agents already in bandages that are prepackaged, so we don't have to do anything. But other times, there's powder that we can pack into the wounds and start that clot formation so they stop bleeding. And it's used primarily for junctional areas, the groin, the shoulder, the armpit, the neck, where tourniquets can't be applied, and yet there could be severe bleeding from those locations. So hemostatic agent, you put it on there, you put some pressure on there, and it binds. It's like an auto clotter rather than counting on the clots of your blood. You get exterior help with that. Obviously, when we're doing bleeding control, we've got gloves on, always gloves on. I would stay away from the latex gloves. That is typically frowned upon in most medical circles. For the more you're exposed to latex, the higher your chances of you becoming sensitized and allergic to it. Now, if by some chance suddenly you're exposed because there's blood everywhere, just make sure you wash your hands off as soon as possible with soap and water. After you wash your hands or maybe even before you can get to it, you can throw down with some hand sanitizer, and that would work too. All right, let's talk about wounds. A wound is an injury caused by any physical means that leads to damage of the body part. We have open or closed wounds. So we'll start with closed wounds first. It's where the skin remains intact, right? Your closed wound is a bruise. Small tissue's been damaged, small blood vessels been broken, and it becomes discolored by that bleeding that is coming from underneath. Now, simple bruises heal fairly quickly, a couple of days, right? But bruising that's immediate can be a sign of underlying fracture. Now, when we talk about open wounds, we got tons of open wounds, right? This is an abrasion, scrape, road rash, rug burn, whatever you want to call it. And it's when skin is rubbed across a rough surface and you tear off that top portion. It's weepy, it's painful, and yowza. What are we gonna do with those? You're just gonna keep. It's probably capillary bleeding at worst. Some dry sterile dressings, good to go. How about punctures? If something's punctured in, well, when something's jabbed in, we got to make sure that we have an idea of how deep this is, and we really don't want to pull stuff out, right? So if there's something impaled in there, leave it there. A gunshot wound is actually a puncture wound, but that will leave a bigger hole that we're going to have to deal with, right? Some example, right? You see here somebody that obviously got in the wrong place of a pneumatic air nailer. Whoopsie. Want to make sure that we're not like tearing that off, right? Hopefully he missed the bone. Kind of looks like he may have, or maybe he fractured that finger a little bit. In this picture on B, you're seeing a splinter being jabbed in. That sharp end there, if we wiggle that around, that's going to cause more damage, and so we want to stabilize that. We'll show you that here in class. Our most common type of open wound is a laceration, commonly called a cut. Little cuts don't really need much, but larger cuts I might have to think about putting a tourniquet on and getting really aggressive there. We see here a pretty fairly deep cut. This is through all three layers of the skin, the epidermis, the dermis, and the subcutaneous, down through the tissue itself. And you can see there that little bit of yellow, that's that fatty layer, as it progresses down to the bone. That is a pretty significant injury, though it doesn't look to be bleeding too badly. So that's a good thing. Though if you look at the hemostatic dressing to the right, it was at one point bleeding fairly good. Avulsions and amputations. Ooh, good stuff. An avulsion is a chunk of tissue that's been cut away. So, like a hunk of meat. Now, if the meat has a bone in it, now we're talking about amputations. Okay? So, and they can be as little as a tip of finger or as massive as an entire limb. Whatever it is, you need to do two things. Number one, stop the stump from bleeding. And number two, take that part with you and make sure that you keep it as clean as possible. If possible, put it in a plastic bag so that nothing in, nothing out. Keep it cool but not frozen. And there is the very strong possibility of reattachment. So take it with you. Take the parts with you. Okay. Excuse me, is this your finger? But you see here, this is an avulsion. That's a flap, right? It's just flapping in the breeze. And if I lost that chunk, I take the chunk with me because maybe I can use that, or they can use that in reattachment. Significant bleeding, I would push it back to where it was and bandage it in place. Okay, very minor bruises, really no reason to treat them, right? However, if you want to make them feel better, you can give them an ice pack or something. Other closed wounds, ice, gentle compression, maybe elevate the part. You know, it's what we typically think of when we hurt ourselves. I'm not taking it easy. But if there's some major contusions, like bruising that is immediate over a large area of my limb, I might consider splinting that because it may be fractured and I don't want broken bones moving around there. Any blood, I've got to stop it in the cleanest possible way. Control the bleeding, prevent contamination, prevent the movement of impaled objects, right? And if I have to, I'm going to throw a tourniquet on there. We're going to show this in class, the dressings and the bandages and how to do that. But place your dressing directly on the wound. That's the first step. So think of a salad. What do you put on the salad? You put dressing on the salad. So you're going to put your dressing on the wound, the 3x3 or the 4x4s or whatever else you got. And then you're going to bandage it in place, assuming that you can control it with direct pressure. Here are some of the devices that we have with disposable supplies, ranging from the very small to the very large. And then, of course, the bandage holds it in place. Most of the time we use a roll gauze, but we can use the triangle bandages or really anything that holds it in place. Shoelaces or whatever else if you don't have any of this stuff available to you in the boondocks. But the step one, the basic way of taking care of a wound is making sure that your dressing covers the entirety of the wound, extends beyond it on both sides. And then you're going to wrap your dressing, your bandage, all the way up and all the way down to keep everything in place. And when you're done, you want to make sure you haven't done it too tight so that your extremity beyond that is able to survive, right? We're not putting on a tourniquet unless we absolutely have to. Obviously, right back to it, we're going to wear our gloves. Make sure that we keep enough of gloves. I always carry 2 pairs of gloves in every coat. And I have 4 pairs of gloves in my truck. So I always have enough in case I have a lot of people with blood. Now, just so you know, a face or a scalp wound, you might have a small cut, but it's going to bleed like a stuck pig. There's going to be all kinds of blood everywhere because it's a very vascular area because it's keeping your brain housed there. So there's a lot of blood flow there. But just because it bleeds a lot doesn't mean you can't control it. Very easy to control with just gentle direct pressure. But we have to make sure that if we're doing this on the skull, on the cranium, that we're not pressing broken skull bones into the brain, causing additional damage. Forehead wound, pretty standard. 4x4 on there, wrap them up, good to go. Cheek wounds, this would be the only impalement that we would remove if it's impaled through the cheek, because we can reach both the inside and the outside of the wound at direct pressure. There's just a hole in the cheek, again, gauze on the inside and gauze on the outside, but you got to make sure not to compromise that airway. If I see any brain tissues out, it's going to be a loose covering because I don't want to touch their brain and make their brain wiggle. Okay, that's just not a good thing. We want to move the head as little as possible if we have injuries to the neck and the spine, again with the face and the scalp wounds. We're always watching for the airway. We always want to make sure we're doing the right thing there. Nosebleeds, pretty standard stuff. Unless the patient is experiencing signs and symptoms of shock, I'm going to have them sit down. I'm going to pinch their nose and have them sit forward. Now, we don't want them to blow their nose because then they're going to be blowing the clot out and it's going to be causing more bleeding. Opposite of what we're trying to do. But we're going to pinch both nostrils together for at least 5 minutes. And maybe if we have an extreme nosebleed, maybe we could put an ice pack across the bridge of the nose. Eye injuries, oochie mama. That is my kryptonite. I don't like eye injuries at all. But we're going to need to cover that eye injury up. All right? Cover it with gauze. Have the patient lie on their back, and we got to cover both eyes so they're not moving the injured eye around because the good eyes try to look around. They're both connected, right? We don't ever remove impalements from eyes or take care of the injuries. This is just showing you a pencil to the eye. Obviously, it's a mock-up. We don't want it moving at all. Okay. Neck wounds. Think about neck wounds. Nothing in, nothing out. I don't want the blood to come out. I don't want air bubbles going in. So I'm going to get an occlusive dressing on that as fast as humanly possible. I want nothing in. And an occlusive dressing is a non-breathable device, a non-breathable dressing. Petroleum jelly bandages or whatever. I'm going to stop the bleeding. I'm going to make sure that no air bubbles get in because we can throw an embolus into the brain. And I want to make sure that nothing comes out, no more blood from there. Fairly easy to control. Sometimes we may have to put some pressure below the injury on the artery to get it to stop. But most of the time, direct pressure is going to take care of that. If I suspect anything with a neck wound that I can't control with bleeding, or excuse me, if I have bleeding on the neck that I can't control, then I've got to focus all my efforts on that. Most of the time, I should be able to control it with direct pressure. But with injuries to the airway like that or the neck area, I'm very concerned with airway problems. I'm very concerned with the C-spine problems. We talk about chest and back wounds. Again, this is going to compromise breathing, so we want to make sure that if they have a chest injury, they're in a comfortable position. But if it's coupled with a head, neck, and back stuff, I might have to have them on a backboard. Depends on where we're at. But if a lung is punctured, air is escaping in the wrong area. It's going in and out the wrong area, and we could be dealing with a collapsed lung, which is going to create some very hard issues here. You might hear it called a sucking chest wound, because when there's a hole in the chest wall and you're breathing, it's another opening. When we breathe normally, the only way for air to get in and out is through the mouth and the nose. Now there's another hole in the chest. You might hear it slurping through that blood. We need to make a chest seal there. We do that just like we did for the neck wound with an occlusive dressing, but instead of taping it off on 4 sides, we're only taping it on 3 sides. Because when I breathe out, hopefully that little chest seal will burp itself, allow the air bubbles out. And when it breathes in, it'll slap closed, and we'll be able to clear that problem in the chest. High flow oxygen is always administered here. Already talked about sealing the wound, ABC checks, treat for shock. If I'm doing CPR in a traumatic situation, I've already pretty much lost the battle, but we'll give it the old 1-2 try, right? And then if there's problems with the seal, maybe it's blocked off and creating a worse issue, might have to burp it manually, or maybe you need to make sure that you have a new seal there or whatever. For impaled objects, we don't want them wiggling around. We want them stable because anything that's inside the patient is causing additional damage if it's being wiggled around. We have to transport that object with them. And we might have to cut that object so that we can transport them with it in there. So we're going to have to stabilize and do a really delicate job here because anything wiggling around on the inside of them is going to cause more damage. So we see here, looks like a ice ball being jabbed into, oh, it's in the belly. Okay, an ice ball into the belly. Wow, somebody was very upset. But we're not going to remove that because if we do, it's going to create more damage and more bleeding. Right now, the object itself is creating a pressure against the wound. Yes, there's bleeding, but it's not as bad as if I take that out, right? So we're going to leave it in place. We're going to stabilize on either side of that and transport just like that, which might mean they don't go on a backboard. Now, in this instance, this is low mechanism. You don't need a backboard for this one. Closed abdominal wounds. This is a result from a blunt object, typically a seatbelt, right? But you might see a baseball bat or something like that in the event of a fight. If you see bruises on the belly or marks on the abdomen, we need to be treating that patient for shock because we probably have some sort of internal damage, possibly even bleeding. Think about what's in your abdomen. You got hollow organs down low, but the solid organs are up top. If my solid organs are bleeding, that's going to be worse than my hollow organs bleeding. Actually, I said that backwards. I'm sorry. Um, because if I get the hollow organs to bleed, that means there's significant damage there, right? We want these patients on their back, um, legs up, covered up, oxygen. We want them to get transported as soon as humanly possible. If they're vomiting, you might have to roll them into a recovery position, um, but we need to make sure their airway is stable, vital signs are taken. Don't let them drink anything, and we got to get them out of there. Right? Now, if their belly wound is open, in the event of an evisceration, their guts are hanging out, their intestines are out, the patient needs to be on their back with their knees slightly bent. So we might have to prop them up with some pillows and blankets and things. And we want to cover the abdominal area with dry sterile dressing. That'll be your biggest uh, 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 dressing that you have. And then you're probably going to tape it into place. We're not going to attempt at all to scoop their guts back into place because that's up for a surgeon to do. Right? So we have an open wound, we put the abdominal dressing on there, and we tape it in place. You might be able to tie it. I'm not real crazy about moving them around to get and hold that trauma pad into place. But it's going to be a loose dressing, um, holding it in place because there's no pressure on this wound. It will cause more damage if you put pressure on this open wound. So we want to stop it and kind of keep all the blood in there, but we're going to not be playing jump rope with their guts, okay? Sterile saline over the top to kind of keep it moist because dry guts become very sticky. Then, of course, we also have wounds to the genitalia. Um, those are rich in blood, whether it's the male or female gonads. Injuries to those areas very much a bleeding issue. You'll be able to see the testicles if they've been ruptured and damaged and bleeding. That's going to be direct pressure, and that's not going to feel comfortable. Unfortunately for the girls, that's on the inside, and now we have internal bleeding with that in the case of like a ruptured cyst on an ovary, right? Sometimes you just have to, take a look um, and be mindful. We talked about behavioral emergencies. We talked about some of those things. Maybe some of this external damage to the genitalia is sexual abuse. So we've got to be mindful of that. Rather than just seeing blood, oh, I've got to fix the blood. We've got to make sure that we're taking care of the patient's modesty as well. Extremity wounds are fairly easy to take care of. Those are probably the easiest of the wounds, although the most distracting of the injuries. Dry gel dressing, if that doesn't stop it, then the bleeding, then you need to put a tourniquet on. If it's broken, we're going to splint it, right? It's fairly simple. This is an example of a pressure bandage. You have a dressing that goes on, we got it controlled, and now we put a bandage over the top of it to secure it into place, right? Gunshot wounds, lots of internal bleeding. That's a high mechanism or medium mechanism. Anything into the trunk and the neck, we're going to have some significant issues that we're going to have to deal with. Most assuredly, airway and circulation issues. We're going to have to be watching for that. With a gunshot wound, there's an entrance wound. I'd be ready to look for an exit wound as well. We got to make sure that we're covering both of those angles there, because if we get one stop bleeding and they're bleeding out the other one, we've only, prolonged the inevitable. Treat for signs and symptoms of shock. They got to be moving out. This might be an instance where you're calling a helicopter to come in. If the heart stops in this traumatic, we're talking about a traumatic arrest. Your chances of winning this fight are all but lost, but we exhaust all options. We don't go down without a fight. Of course, we've got bites from animals. I'm thinking specifically about dogs and cats. You might have some other things like goats or horses or cows or something like that. But anything that is a bite or a tear from an animal, definitely need to make sure that it's washed. Definitely make with soap and water, cleaned out, rinsed out, and then control any bleeding. You also want to be able to kind of have animal control quarantine that animal in the event that there's something else that's going on with it. We're going to talk about burns as another part of the soft tissue, and it's where remember the skin is the largest organ in the body, and it covers the entirety of the body, and it regulates temperature. It protects us from bacteria and viruses and this and that. And when we have damage to the skin, well, then we lose those capabilities. And your skin also regulates fluid loss, right? In the form of sweating, in the form of bleeding. Your skin holds all that stuff on the inside. And so with damage to that, we can see that there can be a lot of problems. Well, we've got 3 different degrees of burns. This one right here is a superficial or first degree burn. Superficial or first degree burns deal, relatively speaking, with the epidermis, the outside. Reddened and painful skin, really nothing much else going on here. Characterized, this is a superficial one here. Could also be a sunburn. Okay, that's your first degree burns. Minor to moderate pain, not much you can do for it except, you know, treat them with some wet dressings and take them in if they want to go in. Okay. This, though, is a second degree or a partial thickness burn. It's gone through the epidermis and down into the dermal layers, and it's caused some disruption. We see blisters forming here. Now we have some fluid third spacing. We have some problems here. And as the fluid loss increases, we might have signs and symptoms of shock. Now, we will not pop this blister. For second degree burns with blisters, we're going to treat like a first degree gently. We're going to rinse it off with cool water, and we're going to go ahead and wet sterile dressings. Notice his hair. This is a hairy guy. He's got singed hair around. So this leads me to think that there is a high mechanism here. I'm worried about his airway just looking at his arm. And then we've got the third degree, which is the full thickness burns. Now, there's not very much pain here because the entirety of the nerve endings have been destroyed. So in the first and the second degree burns, there's a lot of pain there. But with a third degree, it's been cooked all the way through. And you can see here he's got some surgical expansion marks because there's a lot of swelling along his arm. And these patients lose a lot of body fluids and very susceptible to shock and infection because the fluids are third spacing, not getting replacement, and we're seeing that there's no protection from the infections. Well, we've seen the degrees, right? First, second, and third degree, superficial, partial thickness, full thickness burns. But how do we understand, how do we know how bad a burn is when we're talking about the extent of the body? Well, we know the rule of nines, okay? Uh, the rule of nines is a method for determining how much, and it's a rough estimate, it's not an exact science, but in the adult, the head and arms are each worth 9%. Head, arms, right, 9% of the total body surface. The front and the back of the trunk, 18%, and then the legs, of course, 9 on front, 9 on the back. So, or 18 on the, 9 on the front, back, 18 total. So you can see here, this is the rule of nines. If I'm looking at the patient and I do the math, 18 plus 18 plus 18 plus 18 plus 9 plus 9 plus 9 equals 100 or 99. And then you add the 1 for the genitalia, and now you've got your 100%. With the children and the infants, it's slightly modified because the children and the infants, they've got a bigger head proportionally speaking to the rest of the body. All right. So what you're remembering here basically is the torso is the 18ths, torso in the backside. The head in the infant, I would classify both the child and the infant in that 18 time frame, but it is logical that as they get bigger, the proportions shift. You got to get from the smaller proportions to the larger proportions. Just a rough, quick estimate. Okay. All right. What causes these burns? Right. Caused by heat most of the time. Right. If it's a thermal burn caused by heat, clean cold water, run it over for a little while, put some dressing on it, or a burn sheet if they're open. Don't break blisters. Treat for shock. They have to be transported to a burn center. Pretty straightforward, right? But if I suck in the burn, if it's a burn to the airway, it's automatically a priority one, and they need to go immediately. We have to support that airway because they're going to start filling up with fluid in their lungs. So you've melted their lungs, basically. How do I know? Well, I'm looking for burns to the face, singed nose hairs, sit in the mouth, difficulty breathing, pain while talking, loss of consciousness after they come out of the fire, those type of things. Respiratory burns are probably the most insidious of all of them because it's internal burning and there's no way to really know what's going on other than by the signs and symptoms. Obviously, they're going to have some breathing problems, and they're probably going to develop fairly quickly, for the most part, unless it was a small injury, right? It wasn't as like superheated air. It's just warm air, a little bit warmer. Maybe we'd have some smaller issues. But when I see those burns, the soot marks and things, that's a high mechanism, right? We're going to get oxygen on them, do CPR if you have to, get transport going on if you have to. Okay? Or not if you have to. You do have to transport these people. With chemical burns, these are substances, right? Acidic or basic, and these are chemicals that are in contact with the skin. And the longer they're in the contact with skin, the more damage it does, right? So first off, we got to get the chemical off of them. If it's dry, we need to brush it away. But then, whether it's wet or dry, we need to flush this for at least 10, 15, 20 minutes. Keep that cool water coming over it to keep the burning down, right? When you're done with the flush, when you get it all cleaned off, then make sure that you cover it with a dry sterile dressing and get some transport going on. Okay? Chemical burns to the eyes, we want to flush those eyes. We don't want them blinded. And there'll be that eye wash station or a hose or something on low. Make sure that the eye is held open so the water can get over its entire surface. And then a loose covering over the eyes, making sure that you get transport arranged for. Electrical burns, we touched on that in the environmental one with the hit by lightning type thing. But if I come into contact with high voltage, I could have some electrical burns. The thing with electrical burns is there's an entrance and an exit wound, right? And it travels along the neurological system. The problem is we don't know where it goes. I mean, we might find the entrance and exit, but what does it do on the inside as it's bouncing around? Typically, entrance wounds and exit wounds have like an explosive popcorn look to it, and this creates irregularities in the cardiac system, which could lead to cardiac arrest and death. So we need to be paying attention closely to the electrical type of issues as they go along there. What else we got here? Make sure that they're not connected to the power before you start helping them. Otherwise, you're going to be lit up as well. If they're in direct contact with power, high voltage, unfortunately, you're going to have to let them just sit there and cook. There's nothing you can do for it. So, and that goes back to the mental well-being of the EMR. But if for whatever reason you get the power or they were knocked free or whatever else, take a look at those ABCs and really make sure, because they have internal burns as well now, and get that transport going on. Now, finally, when we're talking about the soft tissue injuries and all of these things that are going on with the patient, typically speaking, we will see multiple things going wrong in several systems. So we have to be ready for that. We have to prioritize it quickly. Where do I see the bleeding? Take care of the bleeding. I took care of the bleeding. Where do I see bleeding? Take care of the bleeding. Where do I see a problem? So while I'm doing that, somebody else is going to be worrying about airway breathing, right? So we have to take care of ABCs. We may never get out of ABCs, and that's okay. But we need to make sure that we're paying attention to all the signs and symptoms that they're having system-wide, if that's what the mechanism calls for. Okay. Quick review of what we just covered here in Chapter 14. Number one, always take appropriate standard precautions to prevent contact of the patient's wet, sticky, not yours, to you. Make sure that you remember that there's three parts of the circulatory system: the heart, the pipes, and the fluid. The pump, the pipe, the fluid. The heart, arteries, veins, and capillaries, and of course the blood components and cells. Typical reasons for shock: failure of those three things: pump failure, pipe failure, fluid loss. External blood loss possibilities come from capillary, which is ooze, the number one reason, steady flow, venous, and arterial, spurting or surging blood. Most external bleeding can be controlled with external pressures. Most wounds are caused by a physical mechanism, damaging something, classified as closed wounds or open wounds, where closed is skin remains intact or open is skin is disrupted. Open wounds are classified as abrasions, punctures, lacerations, avulsions, and amputations. So when you're doing your DCAP BTLS, your patient assessment, you're looking for these things. And finally, we need to control any bleeding by direct pressure. If that doesn't work, we need to throw the tourniquet on right away. You might try elevating it, but I'm not going to waste time. I'm going to go right to the tourniquet most of the time. And remember, there are three classes of burns: superficial, first degree; partial thickness, second degree; and full thickness, which is third degree burns. They can be caused by heat, chemicals, or electricity. And there, my friends, is everything you need to know about Chapter 14.